So good morning, and welcome to this amazing conference. I am the author of the book, Mistreated: Why We Think We're Getting Good Health Care and Why We're Usually Wrong. And all the profits of the book will go to a not-for-profit, Doctors Without Borders. So I encourage you to read the book and tell your friends about the book, and together we can help to transform American medicine. Let me start, though, by talking about my dad. My father, Jack Pearl, was the son of two immigrant parents. He worked his way through college and dental school. And World War II broke out. He could have stayed safely behind American lines, but instead he volunteered for the 101st Airborne, parachuted on D-Day behind enemy lines. Captured by the Germans, he and his troop, he led a daring escape through the forest at night. Brought everyone back safely, what Tom Brokaw would call the greatest generation. My dad rarely slept, 4 hours a night maybe, until one day he became tired. Went to the physician who diagnosed a hemolytic anemia. His own body was breaking down his red blood cells. And the place that final breakdown happens is in the spleen. And his doctors removed the spleen successfully. He spent half his year in New York and half in Florida. And my brother is Ron Pearl, the chief of anesthesia here at Stanford, and he and I picked my dad's doctors, great doctors. And every one of them knew that after your spleen is out, you're susceptible to a particular infection called the pneumococcus, because it has a shell around it, a capsule, that makes it difficult for the body's defenses to be able to attack it. And all his doctors in New York knew he needed the vaccine. The ones in Florida knew the same. All the ones in primary care knew he needed it, as did the ones in specialty. But everyone assumed that someone else had given it to him. So one day, my dad came out to visit my brother and me. We had dinner at my house. Drove with my brother to Palo Alto, where he lives. Next morning, 5 o'clock, when Ron wakes up for rounds, ICU rounds, finds my dad on the floor. Unresponsive. Spends 4 days in the ICU, unresponsive, 3 weeks in the hospital. Survives that experience, but ultimately dies from the complications. And of course, the diagnosis was pneumococcal septicemia. One of 200,000 people that year to die from a preventable medical error. The American healthcare system is broken. It was designed 100 years ago at a very different time in American history, when there was very little physicians could do. And almost every problem was an acute problem. And the same system exists in America today. It's fragmented, doctors scattered across the community, hospitals in every single town. It's paid on a piecemeal basis. We call it fee-for-service. You get paid whatever you do, whether it adds any value at all. And by the way, most of the time, if you have a complication, you get paid twice. Not a system you would ever use if you were building your house or redoing your kitchen. The technology is 50 years old. The electronic health record today does not have the information in most settings. It tells the physicians what the patient needs. My dad would have been saved if all the doctors taking care of him had a comprehensive electronic health record, but of course they didn't. The systems they used were mainly for billing. 2% of American physicians do video visits. Only about 20% allow patients to check their own information or to schedule visits directly. Technology is left over from 50 years ago. And the outcome is predictable. You spend 50% more than any other country in the world. And if you take the 20 most industrialized nations, we're in the lower half on every single quality measure. Last in life expectancy, second to last in childhood mortality. But here's the interesting part. If I ask people in general, if I ask the audience, how good is the medical care delivery? You might say the cost is high, but most people would say, in quotes, best in the world. There's not a shred of evidence that that is true. And I became very interested in this difference between objective reality and perception. And I went back and I studied a lot of the psychological studies from decades ago. They couldn't be done now. They'd never get through a human experimentation committee. A short distance from where you're sitting right now is the Stanford prison experiment. You all studied it in college. Philip Zimbardo takes normal student volunteers. In fact, he gives them psychological testing to make sure they're fine. Half of them randomly assigned to be guards, aviator glasses. The other half, jailees. They have OR greens with numbers, no names. He puts them together for one purpose. He wants to know, can we change and improve the penal system of America? Within 48 hours, what do you see? The guards see, and I want to make sure you see these other people as dangerous, as criminals. They inflict debasing punishments. They make them clean the toilets with their bare hands. The jailees see the guards as sadistic. They board up the doors. Within 6 days, the whole experiment ends because of the psychological damage. And why I tell you this story is very simple. Everyone knows that everyone else is just a student. But context shapes perception and changes behavior. When I look at more modern brain scanning, what you see is the same thing. In times of great reward or a great threat, the parts of the brain, the reward center, the amygdala, light up, and within nanoseconds, fractions of nanoseconds, the occipital lobes change that perception. And in Mistreated, I write a lot about all these different experiments. I don't have the time today to talk about them. But what I want to start by talking about is the implication. Because most people in hearing this say, maybe it's true, maybe it's not true, it's not significant. So let me give you two examples. Number one out of every 3 times that physicians walk from patient room A to patient room B, they don't wash their hands. It's been studied 100 times. Now think about this. Every physician has to take classes and courses on hospital-acquired infections. By the way, the third most common cause of death now. They all would score 100 on the test. They all know exactly the cause. C. difficile is not transmitted in the air, the most common and devastating problem. It's carried on the hands of people. But in the context of being late, of having an extra patient to see, of something occurring, they see themselves as incapable of transmitting that bacteria. No more logical than the people in the Stanford prison experiment, but just as significant. And that happens in every hospital in the United States, probably not at Stanford, but every place else in the United States. 1 out of every 3 times it happens. One more example. And to me, this is the greatest experiment ever done in the history of medicine. Barry Marshall's a pathologist in Australia. He worked at a hospital, this was in the 1990s, that did a lot of surgery for patients with ulcers of the stomach or the duodenum. As a pathologist, he'd get these specimens. What did people think at the time? Ulcers came from stress, spicy food. The way you cure an ulcer is you take out 2/3 of the stomach. Even though there's a lot of complications of that, it was better than the problem. He's a pathologist, looks into the microscope. What does he see? He sees these bacteria, H. pylori, surrounding the ulcer cavity in 80 to 90% of patients. Does a big series, and he publishes it. And guess what happens? Nothing. Surgeons still take out 2/3 of the stomach. People still tell patients it's caused by stress and spicy food. So what does he do next? He takes an endoscope and shoves it down his mouth and takes a picture of his own stomach. He then goes to the laboratory where they keep the bacteria, takes a petri dish, and he drinks it. He then puts the scope down himself again, and what does he see? An ulcer. He's produced his own ulcer. He then takes antibiotics and scopes himself for the 3rd time and proves he's cured it. In the late 1890s, Koch, K-O-C-H, had the postulates for infectious disease. This proved it better than anything ever done, and guess what happened? Nothing. It wasn't for 15 years till he won the Nobel Prize for Medicine. By the way, almost never given to a physician, almost always to a PhD researcher. That finally, 2/3 of physicians changed their practice. We think of medicine as being so scientific, but context shapes perception and changes behavior. Now, why do I tell you all of this? Because I think if these context-shifting ways can produce these negative experiences, people mistreating each other. I know the ones I describe in the book about misperceptions about money and misperceptions about relationships. How about if it's being used for the positive? What happens if we reshape American medicine, not as the 19th century cottage industry, but as a 21st century approach? Why would we not expect that perception and behavior will change just as quickly? So what do we need to do? We need to integrate, bring together physicians in the same specialty and across specialties, primary care, specialty care, inpatient care, outpatient care. Because as soon as you see these other people on your team, guess what happens? Collaboration increases. Coordination increases. And now you can start to do some of the difficult things to make sure that surgeons operating have enough volume. Not the minimum volume, but the optimum volume. You start to be able to right size the number of physicians. You start to be able to hire more primary care physicians because now you're on a single large team. Number two, it has to be capitated. Fee-for-service cannot succeed. We have a ton of data that says in a fee-for-service world, the more physicians, the more cost. The more hospitals, the higher the prices. You're not going to change the inherent performance of medicine. What we know is the most commonly done orthopedic operation, arthroscopy with trimming of the meniscus, has been shown to have no benefit, even when combined with physical therapy than physical therapy alone. But in a fee-for-service world, that's what happens. And we need modern technology. The comprehensive electronic record provides information. It's why the best organizations are able to control hypertension 90% of the time, whereas the US average is 55. Most common cause of stroke is hypertension. 40% of the strokes could be saved if care was integrated and coordinated with the technology that sits in place, the change in reimbursement that sits there. But it's not. And as I said, my dad's life, too, would have been saved. How about mobile and video? How about that opportunity to offer patients the way to have their care taken care of without missing work, without school, without having to drive to the physician's office? Not for every problem. The opportunity to create that. How about if you have artificial intelligence? If you're able to do data analytics, which is being done today in patients in hospitals, to know who's likely to deteriorate tomorrow so you can intervene today, prospectively, because if you wait for the problem to develop, mortality goes up by a factor of 4. How about if you look at the opportunity to have, as it happens today, a single stroke-trained neurologist overseeing 20 EDs and being able to shorten the time for a patient walking in with a stroke to getting the clot-busting drugs compared to what happens today, saving lives and saving brain function. The opportunities in technology are tremendous. Finally, the last piece is leadership. And although I'm a big believer in team leadership, bringing the expertise of business people, nurses, physicians all together as one, I speak a lot about physicians. Because until you change the physician's perception, you're not going to be able to change the behavior. And the problem is that doctors are never going to trust anyone except possibly a colleague whom they know well and whom they've worked with in the past. And so it's why I focus so much on the necessity to add leadership training into medical education and take fourth-year medical students and have them spend the month in the business school. And by the way, have the business students spend the month in the hospital to help working on the kind of problems that exist. I've had the chance since publishing Mistreated, to be on CBS This Morning, to be on NPR. This month alone, I have 14 places I'll be talking. And everywhere I go, I'm amazed on two things. Number one, how many people essentially agree with what I'm saying. They may not phrase it exactly the same, but they see it as a broken system, one that can be improved. They understand the necessity for bringing people together, integrating them, paying them differently, putting the technology in place. But number two, the biggest thing I've heard is how unhappy doctors are in the current world, not just patients. A third of them are depressed, 400 suicides a year. 58% of physicians would not tell their children to become doctors. It's the greatest profession in the world, and yet they feel like they can't succeed. They're frustrated. It's not about the people. The people are motivated, hardworking. The system is what's broken. And I believe that making these changes, helping people be on a team, having the information they need to take care of patients, paying them, rewarding them for prevention, avoiding medical error, preventing complications from chronic disease, is actually pretty fulfilling. It's just not the system that we have today. So I think that change can happen. I also worry that American healthcare will either simply devolve into a two-tier system where people get less and less care. You're seeing a lot of this debate happening in Washington, D.C. today as people try to figure out which planks can we take away, which coverage can we take away. Or we're going to get disrupted. I teach at the Stanford Graduate School of Business, and disruption is a major area of focus. And increasingly, I'm talking about disruption as being the equivalent of the White Walkers on Game of Thrones. Season 1, what do we know? Maybe they exist and maybe they don't exist. Jon Snow was sent up there to be in the top of the area. He's out looking there. We're not really quite sure. A lot of stories. And then finally, in this season, what do we see? This dragon come by and use the fire, blow it on the wall, and now marching out into the area are all the White Walkers. That's how disruption works. You hear about it for a long time. It takes lots of years, 20 years usually. But once that wall comes down, it happens very, very, very fast. A friend of mine is Devi Shetty. Devi Shetty is a heart surgeon in India. He was Mother Teresa's doctor. If you ask Devi, what do you do? Devi's a U.S.-trained surgeon. He says, I set a price for human life. They say, what do you mean you set a price for human life? He says, every morning there's 30 moms with 30 babies lined up outside of my door. In India, only 10% of people have insurance. I got to tell the families that it costs, by the way, in India, $1,800 for a heart surgery in his place. And if they can borrow the money, the child lives. If they can't, the child goes home to die. He says, if I get the cost down to $1,500 or $1,200, I elevate the value of human life because more kids will live. Some of the low cost is wages, but much of it has to do with the efficiencies. And why did I tell you that? And I want to call Devi a White Walker. He's a good friend of mine. But he's building a 2,000-bed hospital in the Cayman Islands, 1 hour from Miami. The Cayman Islands only have 50,000 people on it. The 2,000 beds, 1975, is for the U.S. It's not very far away. So let me close my comments by going back to my dad. I told you my dad survived that first hospitalization, but he ended up having complications. He ended up having anticoagulation. And as part of that process, he had a bleed into his brain. My brother and I get a phone call, 7 o'clock at night. We take a red eye. We fly to Miami where he's hospitalized. And there are all of his doctors. The ENT doctor wants to do the tracheostomy. The GI doc wants to put the feeding tube in. The neurosurgeon wants to take out a piece of his skull. My brother and I look at the x-rays. My dad's not going to get better. He doesn't want to live like this. We say to the physicians, thank you very much, but no thank you. We don't want anything else done. For the next 2.5 days, my dad is there. We don't see a physician. There is no ICD-9. There is no CPT code for compassion. There's no way in a fee-for-service world that clinicians take the time to comfort a family in their times of greatest needs. The American healthcare system is broken. Together, we can fix it. I welcome you for joining on. Tell your friends about it. and hopefully you'll enjoy Mistreated. Thank you very much.